Good afternoon, everyone. We've still got some people joining, but we're going to go ahead and get started anyway. As you join, please feel free to introduce yourself into the audience chat box in the bottom right-hand corner of your screen. Please also take the poll that's right above that audio chat so we can start to see who we've got joining us today. So welcome to the WAVAR webinar on certification standards. My name is Jonathan Cox. I'm a TA provider with the Center for Social Innovation as part of the Opioid Response Network. I'll be introducing today's webinar. I'm joined today by Dave, Emily, and Alex. And if you'd like to unmute yourselves and each introduce yourselves, please. Dave. Dave, you're on mute.
Thank you, John. Hi, everybody. I'm Dave Sheridan. I'm the president of the National Alliance for Recovery Residences and coming to you today from California.
Emily.
I'm Emily Burkhead. I'm the executive director of the West Virginia Alliance of Recovery Residences.
Alex.
I'm Alex Alston. I'm with West Virginia DHHR's Bureau for Behavioral Health with the adult programs.
Great, thank you guys. So this webinar is an opportunity to hear directly from WAVAR and NAR about future recovery housing plans in the state of West Virginia. As I mentioned earlier, please introduce yourselves in the chat box on the screen and let us know your name and which organization you represent. And then while I introduce this webinar, please fill in the poll. We'd like to know our audience a little bit better to shape future events. We'll be recording this webinar, and you'll be able to review the recording on the WAVAR website later this month. During this webinar, all participants will be in listen-only mode. We encourage you to submit questions in the Q&A pod that will be coming up on your screen shortly, as well as talk with other participants in the chat box. The Q&A pod will be located on the right side of your screen. You can submit questions at any time, and we'll do our best to answer as many as possible. I would say that if we run out of time, we will be happy to produce an FAQ document after the webinar based around your questions. Please listen to the webinar using your computer rather than using a phone line. If you have trouble hearing the audio through your computer speakers, please request assistance through the chat box, and a member of our tech team will respond to you via private message. If you'd like to zoom in on the slides we're sharing today, you can make them larger with the full screen button in the upper right corner of the display pod. To exit full screen, just press the escape key on your keyboard. This allows you to view the presentation without the pods or to switch back to the pod view so you can pose a question or comment. And this webinar will last about 60 minutes. We're going to have an introduction to WAVAR and NAR. We'll then review some pending legislation. We'll get a DHHR perspective from Alex. We're going to have an overview of NAR standards, and Dave will expand on that. And then finally, we'll touch on next steps. You'll be able to download today's slides and other resources using the file share pod, which will appear about 5 to 10 minutes before the end of the presentation. To download a file, click on it with your cursor, and then click Download Files. Now, I'd like to turn the presentation over to Emily, Dave, and Alex. Emily.
Hi, everybody. I want to start by thanking you all for being here. A special thank you to all of the folks that made this webinar possible, both on the screen here with me and behind the scenes. As I mentioned, I'm Emily Burkhead, and I'm the executive director of the West Virginia Alliance of Recovery Residences. Before we get into the details of certification, I wanted to give you a little bit of background about how and why we got to this point here in West Virginia. So it's no secret that we've become the epicenter of the opioid and addiction crisis. We all know that. So when thinking in terms of solutions, something we hear commonly is that we need more beds. And while this is true to some degree, our problem or our need currently exceeds our existing service capacity It's important to understand that not all beds are created equal. A treatment bed, for example, is not the same as a recovery bed. To be more specific, a bed at Highland 7-Day Detox Center is different than a bed at Recovery Point. A bed at St. Francis's 28-day inpatient program is different than a bed at Ray of Hope. So what is a recovery residence? A recovery residence is a broad term describing a sober, safe, and healthy living environment that promotes recovery from alcohol and other drug use. Many thousands exist in the United States and hundreds here in West Virginia that vary in size, organization, and target population. At a bare minimum, recovery residences offer peer-to-peer recovery support and some provide professionally delivered clinical services, all aimed at promoting long-term recovery. The purpose of recovery residences is to provide a safe and healthy living environment to initiate and sustain recovery. Individuals who go to these programs develop resources that will continue to support their recovery as they transition to living independently and productively in the community. So as it stands today, there is no means of regulating recovery residences in West Virginia. What this means is that we have no way of ensuring quality, safety, or effectiveness of the programs. In 2016, a group of housing providers and other interested stakeholders came together in Huntington to discuss this very issue, inevitably deciding to pursue a standardized credentialing process at the local level. With support from our DHHR, they convened a statewide meeting and identified the need to establish a recovery housing organization that would have three main goals. One, to advocate for the recovery housing community. That would include both residents and providers. Two, promoting high standards and evidence-based practices for recovery housing. And three, to build the capacity of organizations engaged in the recovery housing community. In January of 2018, West Virginia's newly formed Office of Drug Control Policy released their opioid response plan for the state of West Virginia, which identified key findings and recommendations in the areas of prevention, early intervention, treatment, overdose referral, supporting families with substance use disorder, and recovery. In the area of recovery, the plan recommended a broad expansion of peer-based recovery support, including the number of peer recovery coaches in our state and the number of recovery residences that meet peer review standards established by the National Alliance of Recovery Residences. With the state support, the West Virginia Alliance of Recovery Residences, or WAVAR as we call it, was formed that summer and received official NAR affiliation last September. Important to note here is that NAR only designates one affiliate per state. So since September, we've been laying the framework for adopting and implementing our state's process of certification. Our board of directors was formed in December of 2018. Comprised of 12 people total, our board includes at least one person from all 7 regions identified by the Governor's Advisory Council on Substance Use Disorder. 75% of our directors are recovery housing providers. We have 3 clinicians, 1 attorney, and 1 higher education professional. Most importantly, 9 of the 12 people on our board identify as people in long-term recovery. We discovered in our first board meeting that we collectively have over 100 years of recovery in total, which I think is pretty amazing. Our board officers were elected last month, including Board President Kevin Knowles from Berkeley County Recovery Resource Center, Marie Beaver from Ray of Hope, John Dower from Ascension Recovery Services, and Frankie Tack from WVU. More recently, we've also gained legislative support that we'll discuss later in this hour. As I mentioned, WAVAR is still very early in our development. The purpose of this webinar is to primarily let you folks know that we're here and that recovery housing certification is in the works. We don't expect everything to change overnight, but what we do want is for you to be as informed and prepared as possible so that when the time comes, both you and your organization are ready, and we'll be here to support you along the way. With that, I'd like to turn it over to NAR's National Board President, Dave Sheridan.
Well, thank you, Emily. So I'm Dave Sheridan. I'm with the National Alliance for Recovery Residences. And what Emily just talked about is actually going on in a number of states around the country. We'll talk a little bit about that now. But first, thought I'd give everybody a bit of a background, especially those of you who are recovery housing operators, that you're part of a long tradition. The first records that we have that are reliable in the literature, both social literature and research and anecdotal, dates back to the 1820s, 1840s. And the idea that people with substance use disorders needed safe places and safe environments to recover in is of course not new. But there are some milestones along the way that have helped define what our field looks like. In the mid-1900s, of course, we had the founding of Alcoholics Anonymous. And based on a lot of the principles in that fellowship and fueled by a lot of the people that were getting sober in Alcoholics Anonymous, the roots of the social model of recovery developed, which was an offshoot of a larger social model discussion that was being had in sociology and social work. But the idea was really launched in the mid-1900s and was eventually codified and formalized in, I'm going to pull up something. I'm having a little tough time reading this. An organization called AHAP, the Association of Halfway House Alcoholism Programs, applied the social model in a residential context and really developed the first credential that was available for the operation of recovery housing. Later in the last century, we had the founding of Oxford House in 1975. It was a group of individuals who were all of a sudden losing the operator of their housing, decided to take it on themselves and build a whole model around that. Later in the 70s and 80s, some of the organizations that are now parts of NAR began to form, again, around the social model, and that was the California Association of Addiction Recovery Resources, which has a different name today, the Georgia Association, the Sober Living Network, organizations in Minnesota, in Michigan, and then in the early 2000s, a few more of those regional groups, and the advent of regional standards that these organizations, as they evolved and grew, began to realize that they needed to formalize the way that they not only approached the operation of residences, but communicated with the public about what was and wasn't a good practice. And along in, early in this century, in the 2000s and 2010, significant expansion in the numbers of residences and the bed capacity, recovery models that are present. A lot of it fueled by the Affordable Care Act, even though insurance doesn't pay for most recovery housing. NAR formed in 2011. We developed our first white paper in 2012. We actually merged with that old organization called AHAP and developed first kind of standards version 2 was in 2015. And then the other milestone, of course, recently is the Support Act, where there is some language about recovery housing standards and some language about the kind of client and patient abuse that's been going on in the treatment industry. And today we're in 29 states. So what does NAR do? We set standards for recovery residences. We have a national standard, just released version 3 in November. There's a code of ethics that goes along with it. We've defined levels of recovery support, which I'll go into. And really the whole variety of best practices around recovery housing. We work through state organizations. We provide them technical assistance. We do advocacy and policy work. And WAVAR is your state organization and your link to NAR. We collaborate with SAMHSA. We've had a good relationship with the White House Office of National Drug Control Policy, and we have a network of relationships around the country. This is what we looked like when we founded. These are the organizations that existed when, in 2010, 2011, when we started discussing a national movement, and we've grown considerably today. So that we're in 30 states. The blue states are where we're working with either a state agency or an operator group to form the statewide network. We actually at NAR don't do the hard work. Emily's organization and the operators in West Virginia are going to be doing the hard work. So we work hand in glove with the state groups, but it's the state organizations that will engage with operators and really run by operators, do all the other things that you'll hear about as we go through this. So really the way the system operates is that recovery housing providers join their state organization. State organizations together really are NAR. NAR exists as an umbrella organization, really a board and volunteers. And then best practices from all of you around the country come together and are redistributed back out. Now that pretty much is an overview of the way recovery housing works at a national level. There is some legislation in West Virginia that's pretty important that we talk about, so we'll spend a minute or so on that. It's West Virginia House Bill 2530, and some of you may know a little bit about this, but it has passed both houses of the West Virginia legislature, but due to a technical anomaly in the bill, the governor was unable to sign it. So it is back to the legislature to make a technical amendment and hopefully repass in and out. What it does is it will provide recognition by the state for the superior value of recovery residences. It names the NAR standard as being the basis for that recognition. It will create a voluntary certification program, which we're going to talk about a lot coming up. And the certification program will be administered by WVAR under the Department of Health and Human Resources oversight. And it will provide some operator benefits, which I want to talk about next. So first of all, it's going to provide information to the public who currently doesn't know where to go, where to send a loved one, where to recommend, what's a good operator, what's a bad operator, who offers what I need. And it's going to provide recognition to providers for offering this superior level of operation. Once the transition period is over, referrals from the state-funded, state-operated programs will only be able to go to certified residences and providers. It will also provide you access to future funding streams and paid placements, which are kind of like referral, but there's money that comes with it. And also some resources that for supporting the program. So it's a pretty exciting thing. And it's going to be a game changer for West Virginia, as it has been in Florida and Indiana and Massachusetts and now Pennsylvania and Ohio. It's really transformed, this kind of legislation and support has really transformed housing in those states. So with that, I'd like to introduce Alex Alston from the State Department of Health and Human Resources, Bureau of Behavioral Health.
Good afternoon. Thank you, Dave, Emily, and John. Appreciate you guys allowing me to join in on this webinar. I'll try and keep my portion fairly short, fairly brief, because I think the most important parts of this webinar today, they're the standards and the timetables that they're going to talk about a little bit later, how to access WVAR. I think those are much more important than what I've got to say. My name's Alex Austin. I'm a program manager with West Virginia's Department of Health and Human Resources, the Bureau for Behavioral Health. In my current capacity, I oversee the Bureau's adult office programs for both mental health services and substance use services. So those include the residential programs and the non-residential programs, the community-based programs that we fund. To start, I just want to take a brief moment to share a little bit about my history. Prior to joining the Bureau, I worked for over 10 years for a community-based agency that provided services to address homelessness. In that role, I worked with many individuals that were receiving treatment in the community or were moving to recovery-based residential programs. I got to see a lot of very successful placements through that role, but it was obvious that, and I have to say, similar to the homeless providers, there was not a consistent set of standards that all the recovery programs had to operate within. So we did see a wide range of programs, a wide range of access issues, and a wide range of outcomes through the placements that I saw. So currently, when we first began to learn about NAR and the ideas that would develop into WAVAR, I know we were pretty excited. We held an initial work group meeting with some housing providers, with Dave and Emily, and we even became more excited about this. We could easily see the benefit to our state by having the programs learn from and support each other as they seek to and as they achieve the set standards that you guys are going to cover a little bit later today. The benefit is very self-evident to us. Now, as has been mentioned previously, the legislation, House Bill 2530, that supported WAVAR was not initially passed. As they said, it was more due to a technical issue with the language in the bill. However, the bill was supported and passed through both houses on the draft unanimously. I think that speaks tremendously to the state's support for this push and the direction that the state would like to see this go. I understand that this bill is slated to be reconsidered with the upcoming special session, and we will be watching those developments fairly closely as a Bureau. To touch on the vision of the Bureau in relation to the standards, I'll just say that BBH wrote the legislative justification for the current draft bill, so it is something that we very much support. BBH has the belief that the adoption of the standards could lead to stronger, more consistent recovery housing options. So I want to reiterate that we are closely watching the developments with the current draft legislation. Historically, from the Bureau for Substitute Services, we have utilized our funds to primarily support residential treatment programs, some peer services, and a few recovery residences. These programs were typically funded through an announcement of funding availability process that BBH uses when beginning new grant opportunities. I would like to direct everyone to seek out our webpage. On our webpage, we have current funding opportunities through our AFAs. We also have directions for our unsolicited proposals. So if someone wants to send us a proposal outside of the current AFA announcements, we can receive those. Typically what we do is we review those and we will hold them for when potential future opportunities arise. As Dave mentioned, there are in the legislation some priorities put in there for programs that will be WAVAR certified. That is one of the main reasons we are very interested in seeing how this progresses and watching the legislation. That could definitely direct how we try and provide our services. I noted that typically we provided treatment services, the vast majority of our funding. With the current SUD 1115 waiver allowing many of the treatment services to be funded through Medicaid now, we at BBH see our role as one that may possibly be shifting in the future. We have all seen firsthand the value of safe, affordable residences for those in recovery. We all hear that there are more beds needed. So we feel that if there is a shift in funding priorities to support recovery residences, we would want to verify that we're supporting the strongest programs that will benefit the lives of those served. We believe the WAVAR standards are a great indicator of programmatic abilities as well. The Bureau is very excited about the opportunities that may be available in the near future. We know this will be hard work for many of you. However, we are confident in the abilities of the recovery programs, along with the guidance and support you will receive from WAVAR and NAR. BBH is supportive of persons in recovery receiving coordinated, evidence-based peer, and recovery services by individuals who have the lived experience, as well as the appropriate level of training, along with the best practices, including the ethics, boundaries, and navigating stigmas that WBAR can bring to you. We're also supportive of quality housing and living arrangements that support people in recovery, as well as being a connected part of the community. DVH anticipates to be working with VAR on recovery residence issues in the very near future. So I want to thank you for allowing me to be here to say that today, and I'm going to hand it off to you.
Dave, I think you may be on mute.
I can't see my buttons. Thank you. And thanks, Alex. The next section we're going to talk about is standards and ethics. Talk a little bit about the national standard, which is the one that's being implemented in West Virginia. And before we do that, let's talk about, we talked about the recovery residence standard. Well, what is a recovery residence? There's a lot of ways to operate recovery housing out there, but at its heart, recovery residents are first and foremost their housing. They're for individuals with substance use disorders, with or without other co-occurring issues that they're also addressing. They're abstinence-based. They're characterized by peer recovery support, and they operate as family-like communities. Yeah, that's the service that we're talking about, which is still a pretty broadly defined set of things. Now, what is it that makes a good standard? We talk about standards. A lot of people think about, restaurant grading or testing, and what we're really talking about is a set of best practices. So the first thing a good standard will do is define essential requirements. What is absolutely essential to operate a service or deliver a service versus what's nice to have. It's also good if a standard's evidence-based, which means that there's some basis in fact for where the rules come from, either experience or research. It's really kind of what goes into defining a best practice. It's something that stood the test of time and geography. A standard's also objective and measurable. It's one thing to say that places ought to be clean and neat, but what defines that? When we introduce a standard that we want people to have faith in, it's got to have objective, measurable things that are quantifiable, that are comparable from residence to residence, and even state to state. The other thing that's important that a lot of people don't think about much is standard needs to be value-free. And what that means is out there in the marketplace and all the people we serve, lots and lots of us have different views about how recovery ought to progress. We have different philosophies of recovery. We advocate different recovery paths. I mentioned earlier that the social model of recovery was, at least in application and refinement, took a lot from Alcoholics Anonymous. But it doesn't need to be a 12-step based format. So a good standard, particularly as applied to something as varied as addiction recovery, needs to separate itself from recovery philosophies and recovery pathways. It ought to be uniformly applicable no matter what recovery path an operator or a program supports. Another thing that's really important, because this resource is serving primarily low-income people with very little access to resources or options. And so a standard's got to be achievable. Most of the capacity around the country, most of the operators get by month to month on residents who pay their own fees. So this isn't like a lot of healthcare services which are paid for by third-party sources like insurance or Medicaid or Medicare. And as a result, costs are an issue because costs mean access. So the standard has to be achievable. It shouldn't require a lot of expensive equipment or advanced degrees, and we've achieved that. And then finally, a good standard has to be accepted. So we've now that the standard has stood the test of at least a few years, and we're in about 30 states. We think we're getting there. So we talked about recovery housing and recovery residences being a pretty broadly defined set of things, but when we started this process and we started looking at the different ways people delivered recovery resident services, we had to have some way to separate terminology that was operating in some parts of the country and meant different things in other places. What we realized, there seem to be about 4 broad categories, which we call levels, and they're differentiated by the type and amount of services that are offered. But at their heart, if you look at the blue bars down on the bottom of the slide, as mentioned before, they're all alcohol and drug-free housing. They all have mutual recovery support. But then as we start adding things like more structured recovery support services, that begins to define the upper levels of housing. I'm going to get into what these are called in a moment. But so level 2s might or might not offer things like assistance with developing recovery plans, personal recovery plans, not treatment plans or case management, but just recovery plan. In level 3, those residences add some programmatic services. It might be resume writing or healthy eating, what we call life skills, that there's some amount of organized, structured information exchange in these residences. Level 4 is what most of us think of as residential treatment. It adds the clinical component, which is the set of services that has to be delivered by licensed professionals. Now, colloquially, we call level 1s, well, this isn't so colloquial. Oxford House is the best known level 1 residence. It's purely peer support, peer operated. There's no notion of a staff or a house manager. If the operator is anything, it's really a landlord. It's run by and for the residents in the household. Level 2 is what is called in a lot of parts of the country sober living, which again is essentially a peer support model, but there is an overlay of structure. There's an externally imposed set of rules and guidelines about how the home is run, and usually one or more people who's in a position of responsibility and authority, might be a resident, might be a live-out staff person, but whose primary responsibility is to see that the environment is maintained. And then level 3s don't really have a name. Some places they're called recovery homes. Some places they're just called recovery programs. Level 4 we talk about is residential treatment. In Massachusetts, they're actually called recovery homes, and all the recovery homes in Massachusetts are licensed treatment, which is why we came up with the levels. Now on to the standards. What are the set of rules then that govern the best practices, define the best practices in each residence? Our standard breaks down into 4 categories: the administrative, physical environment, recovery support, and good neighbor policies. And inside these 4 major categories, there are 31 standard elements divided into those 4 domains, and roughly 100 individual rules. We're not going to have time today to go into all of this, but I do urge you to go to the NAR website, which is naronline.org, and you can download our standards from there. So the administrative domain includes things like operational integrity, upholding residents' rights. A lot of the things in here have to do with the forms and documents and procedures you have for operating your home. It includes things like being financially forthright, having a clear idea of what your mission and vision are for your operation, and the development of staff skills. The physical environment are the architectural and layout and furniture, but it really boils down to two things. Do you provide a home-like environment, and is that environment safe and healthy? And quite a few rules go into this, and our typical affiliate does an annual site review to make sure that these standards are met. Now, recovery support is sort of the heart of what makes a recovery residence different than a boarding house or a hospital or a treatment center. And so what these standards are getting at is how is active recovery support provided? It's what I call the intentional and active creation and maintenance of a recovery environment. It means that there are things you have to do that don't just come naturally, that establishes what a healthy household feels like when you walk into it. Things like how do you help staff and residents come to terms with the fact that they're really responsible not only for their own recovery, but for helping their housemates' recoveries. And how do you cultivate a resident, particularly a new resident, sense of belonging? That, hey, you know, you've had it rough getting this far, but welcome, you're at home now. You know, there are a lot of things that go into that. And finally, there's a set of good neighbor policies. You know, there's a couple of things about this. One, of course, is that we want to be welcome and viewed as a positive contributor in the communities where our homes operate. And more importantly than that is recovery is stigmatizing enough. And a lot of times what is going to help an individual in their own recovery is engaging in the kinds of activities in their home and in their household community that's going to contribute to the neighborhood's welfare, whether it's helping an elderly couple take their trash out or rake the leaves or snow out of their driveway in the winter. There's a lot of opportunities to really help people learn how to go from that isolated state of addiction and substance use to that connected state of community and recovery. And a lot of that has to do with good neighbor policies. We also have a code of ethics, and I'm not going to go through this in a whole lot of detail except to say it's very similar to the codes of conduct you might see for an addiction counselor or a social worker. It's consistent with those other codes. We spent a lot of time in developing this code to make sure there were no clashes. But of course, it does underlie a different set of roles than you find in a clinical environment. It's consistent with the NAR version 3 standards. We didn't find there were any needs for changes to our code of ethics when NAR version 3 was released this past fall. And it is binding on individuals, which includes all the people in a residence in any position of responsibility or authority, and that would include volunteers. So one thing we've added in recent years that we didn't have in our original standard is a residence is going to have to demonstrate they've communicated this code of ethics to their staff and really to the residents too, to help people understand what the people that are serving them are being held to. And demonstrate that this is not only being implemented, but everybody who's engaged in that service work understands that they're bound by it. And there's 20 ethical rules that go with that. The evaluation process for a residence is really composed of several parts. The first, obviously, is a formal application process. So an operator makes a formal application and provides certain information about themselves, their organization, and then the residents as they operate. And then there is a review of residence documents, which first of all is anything that a potential resident either sees or signs. Also things like house rules, things that are posted in the house, marketing materials, policy and procedures, At some of our levels, we require a policy and procedure manual. In the lower levels 1 and 2, we recommend it, but do require that there are certain procedures that are in writing. And then there's a site assessment, which is an on-site visit where we combine two things. One is a structured interview with people that operate the residence. There's a lot of questions, a lot of elements in the standard that really, to ascertain whether or not a residence is meeting those standards, you have to chat with them and find out how it is they do certain things and how they arrive at certain decisions. And then, of course, there's a physical health and safety inspection. And one thing that's really different for any of you that happen to know anything about our prior versions of the NAR standard, a lot of the rules in our early standard were, here are the things we expect that you're doing, so please tell us how you're doing them. In version 3, we've moved much more to an emphasis on show us in your documentation and your procedures that you're doing these things. So there's a lot more in terms of preparation that's going to have to happen for our affiliates who originally started certifying residents under the old standards and now have to go to the new one. And that brings us to really, what can you do now? You've heard from Emily about what WVAR is up to and in the very, very early stages of delivering in West Virginia. So I'm going to go through a few things, and Emily, you may want to chip in as well. So the first thing I recommend is you review the NAR Standards and Ethics Code, which you can download from the NAR site. And Emily, are you going to have that on the WVAR site as well?
Those are both on our site right now. Updated.
Excellent.
Version 3.0.
And when you're reviewing the standard, think about how it will apply in your context as an operator. So you can actually go through a self-assessment process. It doesn't have to be terribly formal right now, because it's going to be a while before certification is a reality in West Virginia. There's a lot of work that has to be done. But you want to get a feel for what the standard's looking for and begin to think about how a particular rule, you would demonstrate compliance with the rule in your operation. You also definitely want to follow WVAR on Facebook. Emily made sure that we put that on the list. She's a lot more social media savvy than some of us. And they have a mailing list. Going to put in a little plug, too, for a workshop coming up next week on the 17th in Flatwoods. I'm going to be there. Emily's going to be there. It's going to be done in conjunction with the state's first ever statewide peer leadership conference.
Peer Recovery Training Conference.
Peer Recovery Training Conference. So we're going to, on the 17th, I'm giving a talk in the morning, and then right after that we'll all excuse ourselves into a separate room and do training until 3 o'clock. We've got a slide on that coming up. Also, you want to find out what some other organizations that have been around a little longer are doing, and particularly what WVAR is doing. Check out their website, which is wavar.org. We're naronline.org. We have a lot of material on our site in the resources section. And also some of our other affiliates, Ohio Recovery Housing and Massachusetts Association of Sober Homes and Florida Association of Recovery Residences, which is the certifying body for the state of Florida. And also that we have NAR has an open call. It's at 11 a.m. the first Friday of every month, and you can sign up on the NAR website for our mailing list and get on that. Emily, do you have anything else other than the conference coming up next week?
I did want to highlight the importance of the NAR website, naronline.org. It is just a plethora of resources. Dave touched on the white paper earlier. everything from what is a recovery residence to why is a recovery residence, what is the role, and then everything in the certification. So that really is your best friend right now. Again, following our Facebook page, if you want to join our mailing list, it's info, I-N-F-O, at WVARR.org. And if you join that, we will be sending out all of the updates as we get them. Here you see the slide about our workshop, and Dave's going to touch on it a little bit too. The peer conference is actually being offered by the DHHR. It is a 2.5-day training. It's the 15th through the 17th. The hotel is booked up, but we do still have spaces available for our 1-day training. So if you would like to come to this and you'd like to learn more, feel free to email us at info@wavar.org, and we'll get you taken care of. That's about all I have.
Excellent. Looking forward to being there. John?
All right, it's that time. I want to give a plug. We've had a couple of questions. We haven't had that many, which means that either our presenters are unusually clear, or it means that you are all a little shy. So if you have any questions, feel free to put them in the Q&A pod. In the meantime, it looks as though we've had a question for you, Dave. You touched on what the social model was a little bit. Can you tell us a bit more about the social model of recovery and what if you're a relative newcomer to recovery housing, I guess that's a little confusing.
Oh, that's a great question, John, and I really should have spent a little more time on that. The social model, well, first of all, let's start with what a lot of us, including myself, when I'm in long-term recovery and I started my journey in an addiction treatment program, and that's the clinical model. And clinical model is I don't want to call it authoritarian, but there's a hierarchy. There's a hierarchy of knowledge and experience, and it's trained, experienced practitioners of specialized knowledge conveying that knowledge to somebody who doesn't have it, very much like a classroom. The social model flips that on its side and values experience rather than credentials. So it's really one of the things that the 12-step fellowships, particularly Alcoholics Anonymous, talks about is one alcoholic helping another. It's the fact that my lived experience in recovery was earned at a great cost, and it may be valuable to you, that I have found certain things, but my authority comes from my experience, not my credentials. And conversely, I can learn a lot from you because you fought some battles and had some wins that I need to have. So there's a real premium, and it's more than just an egalitarian, touchy-feely thing. The idea is, in recovery residence, we want to create opportunities and environments where these interchanges can happen, and that they happen spontaneously and with some authenticity. It's a lot harder to do that than a lot of people think, and it's why it's easy to see how clinical models evolve for the convenience of the staff, because you can just schedule an anger management group at 12. Well, I may have a problem at 10:30 that I need to deal with right now. I just got rejected from a job, and I need to talk about it. Well, that's the social model. I talk to them, talk to my housemates, I talk to my advisor and mentor in one of my recovery programs. That's a social.
Cool. Emily, I have a question for you that's just come through next. Will the environmental scan that WAVAR has done be released? And perhaps you could take the opportunity to just talk a little bit about what the environmental scan is.
Yeah, for sure. So the answer, to be brief, is that we haven't done an environmental scan yet. The same group that John comes from, the Center for Social Innovation, is actually going to be supporting us in conducting that. We've just got our statement of work, and we're reviewing and getting some feedback before it actually gets started. So the purpose of this is to figure out right now what is our capacity in the state in terms of recovery housing. We know about the state-funded programs. We know about some of our private pay programs, but especially with more funding coming in, there are more and more opening every day. So we want to figure out, what are the programs, where are the programs, who are they serving, and how effective is the service that they're providing. So essentially what we'll be doing is, I think it's going to be over a few months of time. We're figuring out now what we can include as part of our application for certification. A lot of these questions would be answered when people get online to apply. Things like, your location, your address, the gender maybe of your target population, the region-specific, things like that. So that's something that we'll be doing over time, and it should help us make more informed decisions when we look at starting new operations and expanding capacity to really figure out where the need is most. And in some instances, there might be a county that doesn't have a recovery residence, but they also don't have any ancillary support services like therapy or medical or anything like that. So we really want to be sure that we're, again, making educated decisions when we're launching these new programs.
Thanks, Emily. Good answer. So for those of you who are wondering whether the slideshow will be available, it is. It's in the file download pod to the right of Dave's head. And also included in that is a number of other documents that may be useful to you in your work. So feel free to download all of those files. So Dave, we've had another question saying, we hear a lot about the opioid crisis these days. How is NAR helping to end that opioid crisis? And what can a state affiliate like WAVAR do around the whole opioid crisis in helping to end that?
That's a great question. The opioid crisis has really, in a way, transformed NAR. When the numbers started coming in New England, we got a call from the state of Massachusetts, and we helped them build their system. More recently, one of the things we did in our standard before version 3 was added a Narcan requirement, and we distributed that information and how to get it and where to get training to all our affiliates around the country. And we were a little ahead of the curve on that. So now a resident certified in our standards will have Narcan in it. We'll have people training at it. And even more recently than that, we, in conjunction with the Center for Social Innovation and the National Council for Behavioral Health, have just released a guide to medication-assisted treatment and medication-assisted recovery for recovery residence operators. And that's available on our website. It's gotten to be a very, very hot issue. There's some emotional issues around that, and the acceptance of medications in an abstinence-based environment. We've done a lot of work with some of our national partners on that. Your moderator today was a facilitator for a national meeting around medications and the opioid crisis in recovery housing. And there's a lot of work to be done, but recovery housing is a huge component of addressing the crisis.
Thanks, Dave. We've had a couple more questions come in. Dave, I don't know if you want to take this one, but someone's asked, does a typical consumer or client start at a level 4 residence and then work its way to level 3 and level 2 and level 1? or might they start at a different area? Can you explain your levels a little bit more? And I know you touched on it, but if you can do that, if you can just give a little more narrative.
Oh, that's sure, John. So when we talk about the levels, we talk about the amount and intensity of the services that are in each one. But what we didn't talk about was what level is right for an individual, and is it based on their recovery experience, their acuity, and the answer is yes, all of that. But we typically see in a level 4 is a resident or really a client in a level 4 residence is someone that needs really a full day environment that encompasses recovery support and treatment. So that those people will tend to be earlier in their recovery experience. And because treatment is expensive and typically if you're having it paid by insurance, it's fairly short term, you're going to need additional support, but not necessarily a therapist. And so the traditional notion that then there is a progression from a level 4, let's say, to a level 2, where you begin to start working, but you still have a safe place to be at night, or a level 1. So there's some of that, but the reality is people can enter at any level. A lot of people come directly from, particularly if it's been they've been in recovery and there was a return to use and they need to get back engaged in recovery. They don't need to go back to the start again or necessarily need a clinical environment, but they need a safe environment. So a lot of our level 1, level 2 residences are, people are coming into those directly from not having been at a higher level of care.
Thanks, Dave. We've had another couple of questions come in, and I think we've probably got time for one more. And I know you touched on this a little bit in a couple of your previous slides, but I think it's worth a final plug. And perhaps, Dave, you can answer this from a national perspective, and then Emily, you can reiterate some of the things you said earlier to give that WAVA perspective. So how do owners or recovery housing stakeholders get to find out about news and best practices related to recovery housing? And Dave, can you give us a national perspective, and then Emily, perhaps a WAVA perspective on that?
Oh, okay. That's a good question. With NAR, we try to disseminate things that are important that we find at a national level, and sometimes things come to us directly. Things that are happening in Congress, or things that happen in one of the regulatory agencies, such as Health and Human Services. A lot of times we're in the loop on those things, and we disseminate that information out to our state affiliates, who then get that information out to the operators that they support. And in other cases, you can come to us. Our organization is, responds to requests for information. We just started publishing a newsletter. So if you go to the naronline.org website, the bottom of any page, you can sign up for our newsletter, and you'll get something once a month from us. We also have that monthly open call, which is open to anybody who has questions or just an interest in hearing about what's going on nationally. And then each of our affiliates has their own communication networks.
So yeah, So I just want to reiterate that what Dave just said, primarily that when they have information that comes specifically to us, for example, as the affiliate, for example, SAMHSA's newly released MAT guidelines, NAR also released their own guidelines for that, and both of those came directly to me as the affiliate. So if you join our mailing list, those are national level things that you would get directly from us. Additionally, again, if you want to stay up to date with us and what we're doing and how the certification process is coming, what trainings we're doing, those kinds of things, join our mailing list, info@wvar.org. The best way to do it.
All right. Thank you all very much. We're out of time now, so I apologize if we weren't able to get to your question. We did get to as many as we could. We will attempt to send out an FAQ document for the last couple of questions that were unanswered. My name is Jonathan Cox. I work for the Center for Social Innovation. I'd like to thank Dave Sheridan, Alex Alston, and Emily Burkhead for being great presenters today. If you have any questions, feel free to reach out through the WVAR website, and you can follow up with Emily and get access to us all. But in the meantime, enjoy the rest of your